Bonjour, chers collègues. Bienvenue à tous. Welcome, dear colleagues. Welcome to everybody. So today is our fourth day in the 5 days webinar series on dengue outbreak control in the African region. So first, before we start, note that this virtual training adhere to the code of conduct to prevent harassment, including sexual harassment at WHO event. So please use the Q&A section for all questions related to the topic, and use the chat for the IT issues or any logistic issues, or if you want, sorry, or if you want to present yourself. For the interpretation, so we have English, French, and Portuguese interpretation. If you want to use one of these channels, please click on the interpretation icon and choose the channel that fits your language. If you want to show caption, click on the CC button down, and you can also hide the caption on by clicking on hide captions. So this webinar is recorded, and your participation express your consent to be recorded. So all session materials and recording will be shared at the end of the 5 days series. Please, at the end of the webinar, you will receive a form. Please fill it. We want to have your feedback to improve ourselves. So the agenda of today, we have two main chapters: the dengue emergency response and the management of dengue outbreaks. Thank you all. So now we start with the first presenter, which is Dr. Samuel Boland. And the topic is comprehensive guidance for public health preparedness and response in WHO Afro.
Thank you very much. Hopefully you can hear me okay. Let me get up my presentation. And I will just move it into presenter mode. And if you could confirm you can see that, and then I'll continue. Great,
yes, we can
sounds good. Hello, everyone. My name is Dr. Samuel Boland. I work here at the World Health Organization Regional Office for Africa. And today I'm here to give you just a very quick overview of a forthcoming document that is coming out to help you with your preparedness and response to dengue. And this is a comprehensive guiding document. So, like I said, the objective of the session is, over only 15 minutes, is just to review what you can expect to find within the document. We're not going to go into the detail of the content, which is beyond the scope of this presentation. So we're going to go over a little bit of the context and justification for the document. We're going to look at topics that have already been covered in this webinar series. For those that have been attending every day, you'll recognize many of those. For those that haven't, it's a great reminder to go back and look at the prior recordings of these webinars in order to use those really in-depth conversations to draw out that detail. We're also going to look at the topics that are within the guidelines that have not yet been covered in the webinar series, as well as go over a little bit of the other useful content that you can expect to find, and then other related tools and resources. So, as you know, just as a quick overview, since 2023, dengue has been a global health, public health emergency graded at level 3. All WHO regions are affected, including Africa, 15 countries reporting over 200,000 suspected cases and close to 1,000 deaths. In accordance with its mandate to provide guidance to member states, AFRO has developed this guidance for public health preparedness and response, which focuses on key response pillars as well as readiness activities in vulnerable countries in order to address potential transmission and generally providing guidance to member states. It's been adapted from existing WHO HQ and other regional guidance, so for example, from PAHO. Finally, it emphasizes the importance of early detection, sustainable measures, community engagement, as well as vaccination in hyper-endemic regions. And it is aligned with the WHO global and regional strategies, including the Global Arbovirus Initiative, as well as regional frameworks in the African region. It is designed very much for public health officials, but also policymakers, healthcare providers, and researchers, and intends to provide a framework for coordinated action and informed decision-making in the fight against dengue. It will be available in English, French, and Portuguese as well. So things that have already been covered, so I'm just going to breeze past them because in this webinar series, this has been addressed at length in prior sessions. The content covered within the document includes the global epidemiology of dengue, as well as the epidemiology in the Afro region and the risk classification. So for those that haven't yet seen this, countries have been classed into 3 categories. We have tier 1, which is active outbreak for emergency response in bright orange. Tier 2, high criticality score for readiness. And tier 3, countries that have a medium criticality score, which means that they should be looking to advance preparedness activities for dengue. In addition to that, the document also goes over case definitions, the pathophysiology of dengue, diagnosis and differential diagnosis, clinical diagnosis, which is a bit different than those surveillance diagnoses and case definitions that we referenced, case management for dengue, integrated dengue surveillance systems, dengue vector surveillance, and integrated vector management for dengue. So like I said, I'm not going to focus on these at length. There have been dedicated webinars about each and every one of these different components. And you can also expect to find all of this reflected within that comprehensive guidance as well. So I'm not going to go into detail about these, though you're welcome to ask any questions in the Q&A if you wish. So like I said, all of these documents have been covered in the past few days. So some of the things that, unless I'm mistaken, because I know there's been some changes that have not yet been covered in the webinar series, but you can find guidance within this guiding document, include various different topics. So one of those topics is vaccination. And just because there's been some key and very recent changes to this, I am going to very quickly overview the guidance related to vaccination. So there has been very recent change as of October of 2023, so just really a few months ago. So there's a new vaccine, Dengue, and the live attenuated quadrivalent dengue vaccine developed by Takeda has demonstrated efficacy against all 4 serotypes of dengue in baseline seropositive children, that's 4 to 16 years old, in endemic countries, and against serotypes 1 and 2 in baseline seronegative children. SAGE recommends that the vaccine be considered for introduction in settings with high dengue disease burden and high transmission intensity to maximize the public health impact and minimize any potential risk in seronegative persons. Further, SAGE recommends the vaccine be introduced to children aged 6 to 16, and within this age range, the vaccine should be introduced about 1 to 2 years prior than the age-specific peak incidence of dengue-related hospitalizations. The vaccine is intended to be administered in a 2-dose schedule with a 3-month interval between doses. And finally, SAGE recommends that vaccine introduction be accompanied by a well-designed communication strategy as well as community engagement. So I know that that's very high level. There's much more detail within the guiding document, which is forthcoming and which we're very excited to share with you. But I did want to bring this new and exciting information from SAGE about this new vaccine and this new tool that we have that is relevant for both preparedness and response, especially in hyperendemic areas. So related to designing those community engagement strategies and making sure that we have good communication strategies in place. Another thing that the webinar series goes over, in addition to vaccination, is that risk communication and community engagement, including core principles differentiated by the different phases. So in the preparedness phase versus in the response phase. So there's multiple pages to help guide you as at the country level in making sure that you're developing, adapting, and targeting your risk communication and community engagement strategies effectively, depending on the burden of disease that you face. The document also goes over recent research developments, as well as potential new research areas for dengue control. And just to give you a sense quickly of how comprehensive we're trying to be to provide the best support that we can to you, I just wanted to really zoom in on this RCCE core principles during the preparedness and response phase. So within the chapter related to RCCE, within this document that you will have circulated to you and made available to you very soon, it's finalized, it's just going through the publication process at this moment in time. That includes, and again, separated by the preparedness phase and response phase, reflections on community engagement, reflections on community data for action, reflections on monitoring and evaluation, reflections on systems and coordination, reflections on capacity building, and also reflections, of course, on risk communication. And as stated, that is adjusted for both the preparedness phase and also the response phase. So hopefully you're starting to get a picture of the kind of detail that we've tried to go into related to each of these different topics, including the ones that have been previously covered in prior webinars, to allow you and give you the resources that you need to really substantively develop effective strategies within your countries. Now, one of the things, the sort of final section, really, of going over the comprehensive guideline is to reflect concretely on other useful content that you can find. Actually, more than half of the document is found within its annex. And this is in order to be sure that you have not only the content, but also the tools, the guidance, the methods, and so forth that you need to be sure that you're advancing things as effectively as possible. So when you look at the document and when you receive that document, please, please, please be sure to reflect on the tools and the resources that have been made available to you in the annex. It's not a bucket where things that don't really matter have been put. It's actually where we've put a lot of really core content that may or may not be relevant to you, interesting to you, or useful for you. So for example, that includes the risk classification methodology. So when I showed you that map previously in this slide deck that showed tier 1, tier 2, and tier 3, there's an extensive reflection on the methodology that was used to design that risk classification, which is really key because that's actually what then guides the interventions that you make. At great length as well, the document goes over the course of dengue illness, as well as the initial clinical assessment that you're going to be making. So there's actually some case management guidance and tools directly found within the guiding document. There's a number of these different decision trees related to clinical management, but also a number of other important components for dengue preparedness and response. So you actually have these tools made available to you. They're at hand. They've been found and sourced from a huge array of different resources and pulled together to be made available to you in one place, like a one-stop shop. Just continuing to give you this sort of overview of what to expect. There's also guidance on laboratory diagnosis, as well as differentiating dengue from Zika infection, because of course, in many places, these are coexisting. There's also key elements for establishing syndromic surveillance and event-based surveillance for dengue and other arboviral diseases. Further, I know it's a lot, but that's exactly the point that I'm trying to make. We have a report template for dengue case investigation. This is an editable form, so you'll be able to copy paste this out and make edits as you see fit according to your country context. We have larval summary report templates, which again can be withdrawn and edited. There's reflections on dengue contingency planning, looking at timely contingency planning, surveillance systems, outbreak definitions, and so on and so forth. There's the global strategy for dengue prevention and control from 2021 to 2030. There's also the framework for dengue preparedness and readiness at the national level. And finally, there's also an extensive list of relevant resources. These are many of the resources that we collected and that we found useful for preparing this guidance. So you can go back to the original source data if you have any questions. But in addition to that, there's a large number of other resources that may or may not be useful for you. So the reference section, even though it's there ostensibly in order to make sure that we're citing the guidance that we give, is itself an incredibly useful reference for you as well and for your teams. So the last point to quickly make here about what you'll be able to find in the guideline is that there are a couple of related tools, which some of you will already be aware of, some of you may not be. One of those related tools, which could be thought of as being in conversation with and complementing the operational guidance, is the readiness checklist that has already been circulated to countries. And that's to help map your country capacities against a kind of minimum baseline set of readiness standards. And so many of you will have already seen and reflected on and engaged with that checklist. And then we also have forthcoming an operational action plan. And I know it's either sometime later today or tomorrow, there will be a presentation about the operational action plan. And that essentially takes the recommendations and the guidance found within the guideline document that I've whizzed through at this moment in time and actually digs into some really concrete ways to operationalize it, including costing, human resources expectations, and so on and so forth. So with the 30 seconds left in the 15 minutes that I had with you today, the last and final thing that you can find within the document, right at the tail end, right at the back, is this really crucial piece of contact information. So for you, as you reflect and think through how to make sure that you're engaging and effectively responding to the risk of dengue in your country context, you'll be able to find this key list of contacts available to you. So with any questions that you have, you're able to access these contacts and reach out for additional support as you see fit and as required. That is all from me, and back over to the hosts. Thank you very much.
Thank you very much, Dr. Samuel, for this very interesting presentation. So we take 5 minutes for question and answers. So we have one raised hand. Zachary, could you please activate your microphone? Huriratu Zachary. Huriratu Zachary, your hand is raised. Any question? Activate your microphone. Okay. Domingos. You can talk.
Bom dia.
Bom dia.
Eu queria saber se esses documentos terão, qual é o tempo que terão alguma tradução em português, porque, portanto, quando estão em francês ou em inglês, sentimos alguma dificuldade na sua adaptação, leva algum tempo. E normalmente os documentos vêm primeiro em francês e em inglês, mas depois vêm em português. Eu queria saber se tem um prazo para ser traduzido em português.
Thank you very much, Dr. Domingos. It's a very good question. Truth be told, I am not 100% certain, but my understanding is that the translation is happening concurrently. And so the Portuguese translation should be available at the same time as the French translation because the document was originally written in English. However, when the Q&A session just now over these few minutes has been finalized, I will touch base with my focal point here at Afro, and I will put into the chat a more concrete and direct answer to your question, in case I am mistaken. But I believe that they will be coming out at the same time. But I will get back to you in just a few minutes. Thank you.
Okay. Next, Sylvie Fazin. Any questions, Sylvie Fazin?
Oui, bonjour. Je m'excuse,
Bonjour.
c'était une erreur de manipulation. Je n'ai pas une question. Je m'excuse.
Ok, pas de souci. Okay, I think we don't have more question, and we can go ahead with so the next section, the next chapter is the management of dengue outbreaks, and the first presentation is early warning and response system for dengue outbreaks. Dr. Gildas?
Yes,
Over to you.
thank you very much. Let me share my screen, please. Just to confirm, can you confirm that you can see my screen, please? Good, thank you very much. Okay, good morning, good afternoon, and good evening. Thanks for the organizers for giving us the opportunity to present on the early warning and response system for dengue outbreaks. As information, CSD stand for Early Warning and Response System for Climate-Sensitive Diseases. I will be presenting on behalf of my colleague, Dr. Corinne Merle, who is currently on duty travel for meetings. CSD is designed to effectively predict epidemic for climate-sensitive diseases such as dengue, but also other arboreal diseases up to 12 weeks ahead of the spike of outbreaks. As such, it is a predicting tool and should not be confused with a SORMAS or the electronic early warning alert response in emergencies that was developed by WHO Health Emergencies Program. The design of CSD for dengue was based on the biological relationship between a change in weather conditions and the manifestation of the disease outbreak in a specific district. CSD is therefore not only a statistical system, but also information system designed to support decision-making for national and local health institutions, enabling them to take action mitigating the impacts of an epidemic outbreak risk. CSD is free, open access. English is a default language, but local languages can also be used. EOS-CSD was designed and developed by the University of Gothenburg and the University of Fribourg under the leadership of TDR. EOS-CSD is also implemented by TDR in collaboration with the WHO Climate Change and Health Unit. To use the EOS-CSD, the first step is to calibrate it with the climate data, epidemiological surveillance data, and entomological data when they exist. Ideally, these data should cover at least the previous 3 years for a specific district. Climate data, epidemiological surveillance data are mandatory for the calibration of EOS-CSD. Here, the epidemiological data used are the weekly hospitalized cases associated with humidity, precipitation, and temperature at a district level. After feeding the system with this data, the calibration will be done in a semi-automatic manner. Semi-automatic because the system propose, automatically to users the best cutoff for setting the alarms. Next, it will be up to the users to select the appropriate ones they prefer. EOS is also interoperable with disparate health information system too. It is the case in Laos, for instance. I'm not a modeler, but just to show you here that you have a graph of the evaluation data showing the general parameters, including in green, the probability of an outbreak period. The red line here is the alarm threshold, and above, the blue dots are alarm signals. What is also interesting is that the endemic channel here in gray is based on the real confirmed cases in the districts of interest. Sensitivity here is the percentage of outbreaks correctly predicted by alarms, and this should be as close to 100% as possible. Minimum values of 50% are also acceptable. PPV here stands for positive predictive value. It is the percentage of alarms that correctly predicted outbreaks, and this should also be as close to 100% as possible, and minimum values of 50% are also acceptable. After calibration, the step 2, is to install and use the EOS CSD at peripheral levels. The healthcare workers and staff in charge of disease surveillance and the implementation of better control interventions need to be trained in the interpretation of weekly information of the dashboard, meaning that EOS CSD is a dynamic predicting tool. The dashboard is user-friendly and can be easily interpreted by frontline health workers and staff. Above the alarm threshold here, you have different levels of signals. Initial response, early response, and emergency signals. The frontline health workers and staff can take the appropriate responses or actions depending on the level of alarms. Risk mapping is also associated with the level of alarms and will guide the frontline health workers or frontline teams to focus on the districts that are most at risk. As you can see here, the responses may be the investigation of positive mosquito breeding sites. It could be larvicidin or also fumigation, etc. Guidance for implementing EOS CSD is available on TDR website. TDR and its partners are currently supporting 17 countries with the implementation of EOS CSD for arbovirus outbreaks. The objective is to integrate the EOR-CSD into the national disease surveillance system. And this has already been achieved in a few countries, such as Mexico. Currently, we start a discussion with two new countries in Africa, I mean Burkina Faso and Nigeria for pilot test. Colombia and Thailand have been conducting the evaluation of feasibility and effectiveness of EOR-CSD on early vector control responses. Over there, the calibration is already done in both countries. They have also defined the decision algorithm and vector control responses. The staff at central and peripheral levels have been trained. More interesting, in Thailand, they signed a memorandum of understanding with the meteorological department to connect the meteorological and EOR-CSD servers to get automatically climate data on a weekly basis to feed EOR-CSD. Very interesting and big achievement. Currently, they have been conducting a study of feasibility and effectiveness in terms of the workload of vector control activities. The question, could the EOR-CSD be implemented in African countries? The short answer here is yes. Let us recall that EOR-CSD needs at least meteorological and epidemiological surveillance data. Meteorological data can be available through open source websites, while epidemiological surveillance data needs to be provided by disease surveillance system in countries. Based on the assessment of country capacities in Africa for the surveillance and the control of arboviral diseases that TDR and the NTD conducted in collaboration, of course, with the WHO Regional Office for Africa, we noticed the shortfalls in the capacities of for the surveillance of arboviral diseases in many countries, as shown on this map on the right side. And more detail can be found in this report. However, EOR is piloted in Ethiopia for meningitis, for dengue, for malaria, and in Mozambique, they are testing EOR for malaria. It will be also interesting for African countries to use, to pilot test and to use and implement EOR-CSD, as this predictive tool may trigger a cost-saving early preventive responses, considering human and budget constraints in the region. The plan for 2024-2025 and beyond is to continue to support countries for the integration of EOR-CSD into the national disease surveillance system and to demonstrate the effectiveness of EOR-CSD for early vector control response in Thailand and Colombia. TDI is also keen to support African countries willing to use this predicting tool. And as EOR-CSD aligned, aligned with Pillar 1 and 2 of the Global Arboviral Initiative that our colleague Diana presented yesterday, TDR will continue collaboration effort with this initiative to push the agenda forward. I would like to thank these colleagues and the resourceful person we work with. I mean, at the University of Gothenburg, Dr. Leif Yuschen, at the University of Fribourg, Dr. Axel Kroger, a former colleague of TDR, and within the WHO Climate Change and Health Unit, Dr. Elena Villabos-Prats, Dr. Diamond Campbell-Landrum, and I will stop there. Thank you very much, and happy to answer to questions. Over to you, Chair. Thank you.
Thank you, Dr. Gildas, for this very interesting presentation. So after Dr. Gildas, we move to the next presentation, intersectoral collaboration in outbreak management with Dr. Thiebry.
Okay, thank you very much, Dr. Jacques, my colleague, and welcome. Can I share my slide, please?
Yes, please go ahead.
Okay, fantastic. Okay, how is it now? Can you see the slide?
Yes, we can see it.
You can see the slide?
Yes, yes, go ahead.
Okay, fantastic. Okay, thank you very much, colleague. And there will be a video to watch for few minutes, and then we will continue, please. Okay.
Dr. Tiblin, we can't hear the sound now.
Can you hear the sound or no?
No.
Okay. Oh, sorry. Maybe I need to. Now? Can you hear?
No, it stopped. The video is stopped.
Okay. I'm going to share the video. Choose video. Okay. Or you can play the link.
Okay, I'm going to share the video.
But you still you cannot see?
We can see, but there is no sound.
Okay, yeah, you can do your side.
Okay.
Okay. I will stop from here. Thank you. Okay. I will you can present.
Yeah, stop sharing, please.
Okay. Yeah. Okay. Thank you.
Recent health emergencies like COVID-19, Mpox, and Ebola, as well as other zoonotic diseases like rabies, some vector-borne diseases such as yellow fever, and other threats like antimicrobial resistance and foodborne diseases, all illustrate the strong relationship between the health of humans, animals, plants, and the environment we share. For instance, around 75% of all emerging infectious human diseases originate in animals. Human activities, including irresponsible land use and deforestation, result in people and domestic animals encroaching into wild areas. This increases the risk of new or re-emerging pathogens, spilling over between wildlife, domestic animals, and humans. Many other factors can affect the distribution of diseases. The climate crisis has led to unpredictable and extreme weather events like floods, droughts, and wildfires, with a huge impact on animal, human, and plant populations, and the environment itself. Similarly, biodiversity loss undermines the ecosystem's ability to mitigate the spread of infectious diseases across species. Collaboration across sectors and disciplines through a One Health approach is a vital need for addressing the complex health challenges facing our society. No one organization can do it alone. Therefore, the Food and Agriculture Organization of the United Nations, the UN Environment Programme, the World Health Organization, and the World Organization for Animal Health have come together as a quadripartite. They have launched the One Health Joint Plan of Action to integrate and coordinate strategies and actions across the human, animal, plants, and environmental sectors. This new plan focuses on supporting and scaling up countries' capacities in 6 main areas: health systems, zoonotic diseases, neglected tropical and vector-borne diseases, food safety, antimicrobial resistance, and the environment. It promotes the health of humans, animals, plants, and the environment by providing guidance and tools to coordinate multi-sectoral approaches to prevent and manage health risks at the human, animal, plant, environment interface. There is only one planet and one health. Together, we can build a safer, healthier, fairer, and sustainable world for all.
Okay, thank you very much, Mohamed. Well done. And now we will move to the presentation. Very pleased. And that's why exactly we are here today in Nairobi for the quadripartite meeting as well. Okay, let's move to the next slide. Yeah, the next, you see, the One Health, it's not new, it has been reviewed, the definition has been reviewed by expert panel, by the quadripartite, and probably some of you as well, which really it is a way to mobilize or an approach to mobilize multi-sectors, discipline, and communities composed of individuals. So preparedness, individual, community, government structure, you can see how that is really very important to tackle the health and ecosystem issue. So that's the definition which has been endorsed, but it is not new even in the region. Since 2010, you can see the region was engaged into adopting One Health concept and operationalizing it as well. This framework was proposed, and the framework, you can see the monitoring, which is really you have to collect data, epidemiological data, and emergency issue data, and work on it by these three pillars. You have preparedness, response, and then you have this phase as well. So the advice which was given in the framework was to really establish an epidemic management committee. I don't know if many of you have seen the framework, but the framework endorsed is in line with integrated disease surveillance and response strategy, which support the implementation of IHR, International Health Regulation. You can see how the link is. So it's not waste of time. Today we develop another tool called REPREP, Response Preparedness to Zoonotic Disease. It can be used for other health issue, which really other health issue at the human, animal, and environment and interface. So let's move a little bit for the general, the model for vector-borne disease, and where really dengue fever is one of those vector-borne disease. It's complex. We have heard a lot. Most talk were concerned about this, about human, but really this ecosystem issue is not simple. It is a complex. That's why One Health approach is very important. You can see the wildlife, for example, sylvatic cycle here. That really is a serious question. Then other domestic animals are around, the environment, the vector, the principal carrier of the virus is Aedes, which likes water as well. Like, that's how it is, the aquatic lifestyle. Then you have humans. So this is really, really a complex issue. So to address this, you need an integrated approach. There is no way around. Integrated approach, transdisciplinary, multi-sectoral, and collaboration, all are key. And it cannot be done without ecological management. And that needs to be sustainable because the vector will adapt. Okay? So look at this. This is a blueprint which was proposed. This blueprint tell you the upstream factor. You have all heard about this, the upstream factor. Then you have the really interaction as well. So it is not simple. All these factors together will lead to the emergence of disease. And including dengue fever. Dengue fever. So if you have this complex issue, again, a transdisciplinary approach is needed. Collaboration is needed. Multiple sectors, even tourism, you need to work with them. So you got that information and you can work on it. It was published by Wilcox and one of our collaborators. We work together to build the capacity to address this complex issue. And platform will be ready for all of you soon. So the joint outbreak response really requires several disciplines, several sectors at different levels. We heard that the central level is well equipped, but what about the lower level? This is important, but these sectors are known to be very important, but without forgetting environment and other sectors. They are all key. So communication needs to be vertical and horizontal as well. So that's how a really collaborative work is important, is needed to address the outbreak for zoonotic disease and vector-borne disease as well. We know some vector-borne disease are zoonotic disease. So we organize a workshop, and to develop framework based on this, we require 50 participants maximum to work and develop this one. That's why I put this slide on, and that's what we do. Now, the principle was well described in the review of scientific literature published by WOHA, World Organization for Animal Health. And it was based on the Rift Valley fever, FAO and WHO, and WOHA as well, because the colleague who wrote it, they worked for De La Roque, for example, worked for the three organizations. They came up with framework which can be applied for dengue and other diseases. So the framework, we describe that framework and we use it in the tripartite guide to addressing zoonotic diseases and other health events at the interface. So coordinated investigation and response, it is a key. That's one of the tools already we have. So I will give you the highlight of that tool for joint outbreak investigation, for dengue or response. We really need some key pillar, and this key pillar can be several, but the way we do it, colleagues will work on the technical card and use them for environment, human, and animal health. So these different activities, for example, we know environmental surveillance is a key for it, and control as well. So they can put all those elements, for example, in the environment here. They can put all what needs to be done for the environment, what needs to be done for human, what needs to be done for animals. So this, you just interchange this as you like, okay? So, okay, coordination is very important. For example, for dengue fever outbreak or Rift Valley fever outbreak, it doesn't matter. And you really need a coordination mechanism, which we establish at the regional level and at the country level as well. There is a coordination called incident management system. That's one way. But if you already have the coordination mechanism built in the country, you can adapt it directly, because you know you have done you develop some of the framework, and you can use a shift around. But when it comes to surveillance, be very careful. It cannot be limited to human sector, human health sector alone. It's impossible to work out. You have seen how this predictive modeling takes environmental climate change into account to come up with good prediction. For example, we do have a tool as well to support that coordinated surveillance. And the tool will allow you to collect data on to build the capacity at the country level, so they can all bring the data together weather condition, which you have in animal data, public health data, water, and vector. All together, you can have really a nice dashboard and work on it. So it helps in terms of, because surveillance is key for disease control. No question about that. Dengue fever is not an exception. Okay, so the tool exists to support that coordination mechanism. If you want, you can pass by the WHO country office or WUHA, or if you have a WUHA delegate or FAO or UNEP, even they will get in touch. We can support your country to use any of these tools. The tool develop almost a joint risk assessment. Some of you have done it. Investigation, we are piloting it. Multi-sectoral, One Health coordination, it is ready. Surveillance is ready. And risk communication, we do have a place for that one as well. Workforce development, it is in pilot stage. Your contribution is welcome all together with national bridging workshop to improve collaboration, to prepare and to respond, to detect are key. All will contribute to the joint plan of action you have seen right in the video. And the focus, for example, if you look at dengue fever, it is classified here in action track 3, where you have neglected tropical and vector-borne disease. But vector-borne disease in the joint plan of action, as you can see, you have 3 actions to the objective, and you have this action you need to develop. These are sub-specific objectives, and within each of them, you have 3 or 4 activities in the document where you need to really build the capacity for dengue and other vector-borne disease. Now, you have seen the joint plan of action. It is a collaborative work for the 4 agencies and their partners, whether they are financial or technical, academic, contribute to it as well. We have guidelines as well to support country to implement this, to align the national One Health strategic framework or strategy with these guidelines. And the UN, all the UN team in the country, they receive this one. If they haven't received it, it is online, they can use it. So we have enabling environment in the region, regional strategy to ensure health security in the region. The way we do it, we have 3 flagship projects. Each country will benefit this project, really. It is emergency preparedness and a response. These 3 pillars are here. You have this, which is called promoting resilience of health system for emergency, and as named PROS, and you have tasks as well in abbreviation here, acronym, and you got search. When we come to response, do not think these pillars are separated. We all work together. It is really a One Health approach. We take this one. We have experts from different disciplines, from different sectors, and they work at country level as well. It is the same. When the search training program strengthening and this program was created, it includes, some of you have been trained about all, with experts from laboratory, epidemiologists, anthropologists, veterinarians, and you can name it as the list is really large. So we have an environment for even dengue. We just need to work together to bring expertise together to tackle. Here is the tool. This tool, even though it's not predictive, but it's called epidemic intelligence from open source. This epidemic intelligence from open source training have been conducted. It monitor all the media, so you can use it. It is a One Health tool. It is operational now. When we presented this 2018, it was in development, but now it is presented. You have other operational tools. You have tools for national health security as well to improve collaboration. To summing up, for dengue, other disease, mpox, Rift Valley fever, take-home message. It is bringing together and really and coordinate activity are key. Necessary to do that as well, you need to establish really a good communication and negotiation mechanism because that's important. If you say you cannot convince colleagues and then or you cannot convince the media, that means your communication skill is questionable because you need to be able to negotiate. That you need to have that leadership skill to really to demonstrate. So it is there should not be a problem here because interest. You look at the interest, option, criteria, agree. So providing you need to be able to provide operational material as well, which might require funding. But if engagement is there, organizing the multidisciplinary team, local knowledge, you have seen it. Local knowledge is very important. We have done projects in tropical disease research, TDR, where you have really various tools, various aspects, emphasis will be taken into account. Were taken into account. Okay, using evidence-based, you have heard about it several times, and setting leadership and coordination. Setting leadership and coordination is the role of all of us. Otherwise, we will fail. There should be no resistance if this is well done. Okay, thank you very much for your attention. And I'm sorry if apology if it is too fast for some of you. Thank you very much. And I will stop here really. And obrigado, merci beaucoup, spasiba большое. Thank you.
Merci, Dr. Thieblé. Thank you very, very much, Dr. Thieblé, for this very good presentation. So we go to the next presentation with Dr. John. The title is Key Steps to Follow When There is an Outbreak. Dr. John, over to you. Dr. John, do you hear me?
Okay. Mark.
So it seems that maybe, okay. Dr. John, do you hear me? Sorry, colleagues, for this interruption. Please let me call Dr. John and see if he has an issue with his internet or something like that. Just a few seconds. Okay, I think Dr. John is back now. Dr. John, do you hear me? He's getting back to his computer. Yeah, Dr. John, we have you. Welcome back. Dr. John, do you hear me?
1 minute, please.
Okay, great, you are here. Okay.
Are you able to see my screen?
Yes, please go on slide mode.
Okay, 1 second. Okay, I will be presenting some key steps and the principle on responding to a dengue outbreak. I'm Dr. John Ochudema. I'm the Regional Incident Manager for dengue in WHO Afro. I would like to remind that now we have a new global architecture for health emergency preparedness response. You may be aware that now we are under pandemic accord, pandemic instruments, having three main components: governance, systems, financing. And just a reminder, it was come up for multiple reviews conducted, and those reviews come up with more than 300 recommendations. And from those 300 recommendations, those 10 proposal was actually completed and grouped within the three components we are showing here. In the system, we can see elements, part of the system is, first of all, capacity strengthening of teams and institution, coordination, the second element, and collaborations. And this is three key elements for the system. For governance is, first of all, leadership, and leadership include political commitment and government support, regulation, but also accountability. And in terms of financing, it's about putting the global architecture. And we have three key principles: equity, inclusivity, and coherence. Equity is making sure that everyone are covered. Inclusivity is putting in place all stakeholders. Coherence is more related to science, evidence-based. We are talking about dengue outbreak definition. Let's discuss a little bit about the definition. An outbreak, synonymously called epidemic, is a sudden and unexpected increase in case or death of an illness exceeding the expected incidence in dengue endemic settings. This is determined using historical data. Sometimes we are using 5-year data. So this is a definition of outbreak in endemic, settings. But a seasonal peak is different than outbreak. The seasonal peak is an expected increase in case that usually occur during or immediately after the wet seasons. So we understand that the difference between outbreak and seasonal peak. But what is most importantly here interesting is defining outbreak in non-endemic settings. a single locally occurred dengue case in an area where mosquito Aedes vector are known or suspect to be present may be considered an outbreak and will warrant an investigation to determine if there is any additional cases. It's really important because in some non-endemic area, it should be just one case that may be represented. But in endemic settings, we need to have those differences in terms of what is expecting or not. Moving forward, let's go. There is a lot of, several outbreak detection and verification method. First one is epidemic channel. Epidemic channel is used for visualizing the expected cases level using, a standard deviation and so on. So this is, and graph you have on your right represent those epidemic channel methods, And the other method include incidence threshold. And for example, just give an example in Sri Lanka, where they were using over 10 cases per week has in a local area has the threshold. But for example, in Brazil, they were using, beyond 300 cases per 100,000 population has a threshold to see that this is an alert for, a threshold for outbreak. There is a lot of other, method, including moving average, comparing the average for 3 to 4 weeks. If it's go 2 times this average of 3 or 4 weeks, we are talking about, method. We can use also other type of variable, including changes, serotype, profile, and other. It's mainly taking a look on a new serotype that increase. Even overall, it's not increased, but it's a new specific serotype increasing, or there is an increase on, number of deaths related to a specific serotype that can be considered also as an element for. So we have alarm signal. Alarm signal include, excess case reporting, include the threshold. So if you go behind the threshold or using high transmission indicator, for example, a clinic related indicator, that may define that this is an alert. But we can use also some other variable indicator, for example, increase of virus positivity rate, and also increase malaria negative rate in fever patients. We have an example here in Chad where the alarm was based mainly on increased number of, negative testing for malaria, and that may just give an idea on alerts. And other in alarm include also streamlining triggers for early and or late response also can be considered as an alert. Quickly, when we have an event, we have an alarm, we have to conduct, first of all, the risk assessment. Here is talking about the risk management cycle. So the risk assessment is basically to assign the level of risk for calibrating the scale of response. After the rapid risk assessment, we will go through control measure after developing a plan, and then And after that, we have evaluation. This is monitoring response of way forward to the recovery. This is a key and coming up with some lesson learned. So in general, risk-based approach identify the high risk and taking appropriate risk reduction mitigation measure that need to be taking place. But one of the key elements is this risk assessment. The risk assessment, that you will not go through quickly on that. It was discussed last time. It's based on the combination between the likelihood and consequences, and that define which area, is it low risk, moderate, high, or very high risk? This will be depend. I will not too much discuss with that because Dr. Boris discussed about that last time. We have this risk categorization, and characterization is based on context, exposure assessment as our assessment, and that defines the risk is low, moderate, or high risk, or very high risk, or now it's coming up on a response. And from there, we'll be defining which type of activity will be implemented. Is it preparedness? Is it a response? Is it a recovery? Depending on the deliverable. Just a quick reminder on what Dr. Boris presented the first day is categorizing the risk, doing the risk mapping in 3 tiers. The first one is, as my colleague presented just a few minutes, country with needed emergency response, tier 2, country needed implementation of readiness activities, and tier 3, country that need, implementation of preparedness activities. Now, this is now what we call the 5 C's of health emergency prevention, preparedness, and response to, public health events. This five element, 5C. The first one is collaborative. Dr. presented yesterday, Dr. Diana. This is surveillance of mosquito, surveillance of the virus, surveillance of people, and making sure that we collect data outside and report it as much as quickly. The second C is community protection. That includes risk communication and community engagement, but also population and environmental intervention, public health intervention. As said last time, community are playing a key role on implementing activities. So this is a very big component. The third C is clinical care, and clinical care include any referral system, triage, as discussed but last time, but also health facility, first level hospital, second level, and third level hospital, according to the type of severity that may need, for example, third level of hospital with ICU, with intensive care unit. The fourth one is access to countermeasure that include, let's say, integrated vector measures, but also vaccination and supply chain, everything related to operation and support and logistics, grow to access to countermeasures. And the last C is emergency coordination. This coordination need to be multi-sectoral, and we need to go to One Health and related to the global, the global arboviral initiative. This is just an example to give you on a dengue response coordination structure and incident management support that include the incident manager, incident lead, with also some key pillar related to what we just defined as 5 C's but with sub-components that include, vector control lab and all those key elements we relate to. Just mention that some pillar, including here, has all logistic finance are also key as much as other technical pillar. Here is just to give you an example on stakeholders. I know that my colleague Thielbel already discussed it. Here it's really multi-sector, so it involves not beyond Minister of Health, of course, part of the One Health, but also agriculture, Minister of Education, that include NGOs, medical sector, civil society, media, army, for example. We have here the picture of, use of insecticide spraying drone that was used, for example, in Burkina Faso. It was, a joint effort going beyond the health sector that include, environmental specialists, vector control, entomologists, epidemiologists, and so on, just giving you an example, the strategy. Element of success, the outbreak is mainly, the management of the outbreak. As Dr. Rahman said the first day, one of the key areas is vector control, integrated vector management, let's say that, but also other activity related to community and management of health services. Here, I'm sharing with you good practices leading to an effective outbreak management that include timely contingency planning. It's better to have a contingency plan when we evaluate the risk and we come up with a contingency plan. And it's better to have a preparedness plan, a readiness plan when we completed this exercise. And then moving forward, the second element is a strong integrated surveillance system, surveillance of virus, mosquito, and people, as we said yesterday. This is really key, combining and collaboration between lab and AP and so on. The third one is outbreak definition, as we just discussed here, that need to be adapted for each countries, and coming up with an alert system, really strong and sensitive, also reinforcing capacity, managerial capacity in terms of finance, including, just remember the global structure of the outbreak. It's really important to reinforce collaboration and all those components. The vector control, of course, and clinical services are part of effective component of effective good practice of effective management of outbreak. In conclusion, increasing dengue outbreak in the African region pose a health security threat, requiring effective outbreak preparedness and response. WHO is advocating for a risk-based approach using the emergency response framework for dengue outbreak, but also for other outbreaks. Timely outbreak detection, risk assessment, as we discussed, and proportionally response are crucial in managing outbreak efficiently. Countries should, establish triggers for response through various surveillance mechanisms, as discussed last time. Coordination of outbreak is important with vector control, but let's remember that a robust health emergency architecture that includes a very good, strong component of governance, financing, and health system, those three key elements with the principle of equity, as we just discussed, is vital for effective outbreak response. Health system playing a key role on providing an alert system, early detection, and responding to the risk very quickly. But don't forget that communities is the, at the middle of all action will be needed to take into consideration, including risk management cycle. Thank you so much. Here is just to present you some tools, very interesting tools that are available, even online, that will help us to go to some details on how improving our work in terms of steps and the principle of managing and preparing to respond to a dengue outbreak. Over to you. Thank you.
Thank you, John. Thank you for this very interesting presentation. Now we move to the question and answer. So we have 3 raised hand. So Boubemi Roslin, Jack Donmi, activate your microphone, please, and ask your question. Roslin? Okay. Azmira Jibre Lassi. Activate your microphone.
Okay, I would like to ask a question to Dr. John. In the past lecture sessions and including today, the data are from other countries like Brazil, Sri Lanka, and Indonesia are stated multiple times. And our focus on this webinar is on Africa, but we didn't notice much data about African countries, their challenges or barriers, and how they are managing on these scenarios. Because the response to be taken at Brazil or Singapore may not be possible to apply on Libya or Sudan due to war or economic situations. So we need more data on African countries so we can learn more.
Okay.
So I have another.
Bari Yahya.
Oui, bonjour, merci pour cette très belle présentation. J'aimerais poser quelques questions ou suggestions par rapport à Awards CSD. Ça serait intéressant aussi de passer aux pays sahéliens, là où on a de multiples foyers de fièvre hémorragique qui surviennent d'une manière inattendue ou souvent d'une manière vraiment brusque. Est-ce qu'il y a impossible de développer ou de mettre ces pays-là, un des pays qu'on pilote par rapport à la gestion de ces fièvres hémorragiques? Merci. Ça, c'est par rapport à CSD. Et par rapport à Dr. Keble, j'aimerais savoir, c'est la coordination One Health, c'est vraiment une très bonne chose. Mais s'il y a une possibilité d'appuyer les pays dans la mise en place un plan multirisque, ça serait vraiment aussi une très bonne chose si vraiment l'OMS peut apporter un appui par rapport à ça, ou le WAHA ou le FAO, en plus du pays, ça serait une très bonne chose. Par rapport à la collecte de données, bon, en fait, j'aimerais quand même qu'il y ait un appui encore par rapport au système, à la modélisation, voir quel type de données qui pourrait être très efficient pour ces pays de l'Afrique de l'Ouest par rapport aux maladies virales vectorielles émergentes ou résurgentes. Merci beaucoup.
Merci à vous. Dr. John et Dr. Gildas vont essayer de répondre à vos questions. Pour Dr. Tiblé, malheureusement, il a dû nous quitter parce qu'il a une réunion urgente en ce moment. Mais si vous pouvez noter votre question pour Dr. Tiblé dans la section QR, questions-réponses, et elle lui sera envoyée et on vous enverra la réponse. Pour les deux autres questions, il n'y a pas de souci. Dr. John et Dr. Gildas vont essayer d'y répondre.
Merci beaucoup.
David Oueto.
Oui.
David Oueto. Yes.
Oui, bonjour.
Bonjour.
Oui, je commence par remercier l'initiative et les présentateurs aussi. Et merci beaucoup pour ces moments d'échange. Maintenant, ma préoccupation, c'est que il y a quelque chose dans tout le processus que je ne vois pas apparaître. Et je voudrais savoir quelles sont les dispositions en cours pour arriver là, parce que de mon point de vue, sans ces aspects-là que je vais aborder, on n'est pas sûr de gagner la bataille. La dengue, comme pour exemple, est une maladie de la pauvreté. Maintenant, et ça c'est clair, et comment fait-on pour donc aller vers cette cause profonde-là qui, une fois taclée, va régler la grande, sinon la plupart des maladies qui sévissent si nous prenons le secteur des urgences, donc des situations d'urgence de santé publique, comme c'est le cas actuellement avec la dengue. Donc, on va régler tous ces problèmes-là. Pourquoi ne nous attaquons pas à cela? Et on le sait, le secteur par excellence qui devrait être en train de faire en sorte que nous réduisons la pauvreté, ce n'est pas les finances, l'emploi, tout ça, non, c'est l'éducation. Une éducation qui, selon les normes internationales et la science, doit être obligatoire pour tout le monde, alors que nous sommes dans des contextes où 80% de nos populations sont analphabètes. Et nous avons beaucoup d'efforts que nous menons en tant que OMS et autres partenaires, mais qui n'ont pas beaucoup d'effets parce qu'on a un handicap fort de ce côté-là. Moi, j'aimerais que au moins ces aspects-là puissent transparaître. J'ai vu à travers les présentations, sur le terrain aussi, le ministère de l'Éducation va faire partie du processus aussi. Et là, on reproche à One Health de ne pas aller au-delà des 3 secteurs et de rester là seulement alors que les problèmes se posent beaucoup plus ailleurs. Donc, il faut que One Health soit désormais élargi. Et donc, il y a tous ces aspects-là. Moi, je voulais vous demander, qu'est-ce que vous êtes en train de faire dans ce sens-là? Parce qu'on est devant un problème sérieux qui englobe tout un lot de maladies, la pauvreté, l'analphabétisme. Je vous remercie.
Merci pour cette question très pertinente. Nous n'avons plus de... sorry. Thank you for this very good question. We have... I think we have no more question. Dr. John, Dr. Gildas, à vous la parole. The floor is yours.
Bon, je ne sais pas si Dr. John me laisse d'abord ou vous voudrez ou je passe après vous, Dr. John.
Thank you so much. I will start and Dr. Chidas will add. First of all, to define a method or, what it should be considered as threshold or any method for the outbreak detection, that need to be adapted. And we are just giving example of a country who has some very good data. And as I say, one of the key, milestone is having an historical database. And it should be data consistently collected during 5 years. Sometimes it's not necessarily available. So it's really encouraging, and WHO is working on it, supporting country to establish a strong historical data and going through, defining threshold and all of that. Even the estimation of the burden, just remember that Dr. Rahman said last time, we need data to use existing tools to estimate the burden in each specific country. That assumes that those country has data. So the effort for Africa is ongoing. We are working, for example, with Burkina Faso, Mali, to start this process, establishing a strong gathering data, and then going to support the country to define the threshold and or to have an estimate. Just Dr. Rahman said last time, most of them what is reported is far, even 70 to 90% of what should be expected, and we are losing on community part mostly. This is, what we are saying is just the bottom of the iceberg. This is just to say that this is an ongoing effort. Just to recognize effort conducting by Burkina Faso, other countries as well, but it's still ongoing to establish a very good system. And if we establish those estimates, it can be used for other countries and represent example from Africa, of course. It's ongoing process. The secondly, modeling, I just discussed about modeling in terms of estimation. It's I received a question related to can we declare an outbreak in a local area, rural area? It depends on what the country defined as, health district or operational level. So mainly declaration of an outbreak depend on the structure division of the health system in the country. So has presented in Sri Lanka or other countries is based on local area or health district or provinces. We can in each level establish, the threshold. But in some cases, non-setting endemic area, for example, one single confirmed locally acquired cases constitute an outbreak. So this is just to take it into consideration. That's it on my side. Thank you so much for having other mostly comments. We will take into consideration. Dr. Gildas, you can add. Thank you.
Merci, Dr. Jordan. Je vais répondre à deux questions. Il y a la première, en fait, c'était par rapport à celle qui est posée par Dr. Barry Yaya. Donc, oui, effectivement, le Niger, en fait, on peut être aussi considéré, peut être en fait, pris en compte pour l'étude pilote quant à l'implémentation, en fait, de EWAS CSD. Il y a on va vous laisser, en fait, notre email adresse, en fait, et vous pourriez, en fait, nous contacter. Il y a déjà, en fait, normalement, en fait, l'adresse email de ma collègue, en fait, qui est dans la présentation, mais je vais, en fait, remettre ça dans la section, dans le chat box pour que vous puissiez, en fait, nous contacter. Ça, c'est la première question. La deuxième, il y avait une question qui avait été posée par Dr. Nganga Blaise. Ça, c'était dans le Q&A, dans le chat. Par rapport aux difficultés d'obtention des données météorologiques dans les pays africains pour les études pilotes et aussi la mise en place de l'implémentation en fait, de EWAS. J'aimerais juste en fait, lui souligner que c'est tout à fait en fait, les données qui sont plus faciles même à obtenir. Donc, pour l'implémentation de EWAS, CSD, vous avez besoin en fait, obligatoirement des données climatiques et des données épidémiologiques. Ce qu'on a observé, au fait, c'est que ce sont les données épidémiologiques et les données entomologiques qui sont plus difficiles à obtenir. Mais les données climatiques sont vraiment faciles à obtenir. Soit ce n'est pas les stations météorologiques qui sont installées dans les pays déjà, ou soit vous pouvez en fait, aussi obtenir ces données météorologiques en fait, via les satellites. Il y a des données satellites, des données qui sont sur Internet, en fait, donc vous pouvez en fait, l'obtenir pour des districts. La seule, je dirais en fait, le seul point à mentionner à ce niveau, c'est ce que nous appelons en fait en anglais granularity. C'est-à-dire, plus vous avez en fait, des stations météorologiques installées dans plusieurs localités d'un même district, plus en fait, vous serez beaucoup plus précis. Les données météorologiques en fait, obtenues, c'est pas obtenu pas via en fait, via Internet ou via les satellites, en fait, en sont souvent, le niveau le plus bas de l'échelle, c'est souvent au niveau des districts. Parfois, en fait, s'il y a des chaînes de montagnes, etc., en fait, qui peuvent en fait, modifier en fait, ces genres de données climatiques, en fait, il y a intérêt en fait, à avoir en fait, des stations météorologiques. Mais c'est pour vous dire que ce n'est pas les données qui sont difficiles à obtenir, c'est beaucoup plus facile à obtenir. Je vais profiter voilà, pour souligner le fait voilà, que EWAS, l'implémentation de EWAS CSD dans les pays, en fait, a aussi un double intérêt. L'intérêt, c'est que ça amène le pays, en fait, aussi à renforcer son système de surveillance des maladies. Parce que pour la calibration de EWAS, il vous faudrait, en fait, ces données épidémiologiques qui ne sont pas des estimations, ce sont des données réelles des cas de dengue ou des cas hospitalisés ou des cas confirmés. Donc, cela voudrait dire qu'en installant en fait ma EWAS, par la même occasion, vous renforcez votre système de surveillance sur les maladies. Voilà, je vais m'arrêter là. Je pense que c'était les deux questions qui me concernaient. Merci. Je vous passe la parole, docteur Jacquet.
Merci beaucoup, Dr. Gildas. Merci à vous deux. So if there is no more question, I think we are going to stop this webinar. So please, we wish that you will be with us tomorrow. Tomorrow, it's the last session. It's about the risk communication and community engagement. We will have Dr. Tammy Allen, senior lecturer from the University of Australia, James Cook. We will have Dr. Aziza Amina Saeed, risk communication and community engagement officer in WHO country office of Gambia. And we will have Suleiman Koni, health promotion and social determinant of health officer in WHO country office Côte d'Ivoire. So we wish to see you tomorrow, same time, same link. Thank you for being with us these 4 days. Thank you very much and have a good evening. Thanks to all.